That's all right. One of whom I hadn't met until I started working on this celebration, and that is Dr. Roberta Waite. And the other one is somebody I've known the majority of my life, who is my husband, Dr. Fred Wamboldt. So the reason we've invited both of them to give this talk today is that thinking about who is dealing with health disparities in our country, I think the federally qualified healthcare centers are really at the forefront of this work. And Dr. Waite is a professor in doctoral nursing and the associate dean of community-centered health and wellness and academic integration at Drexel University. She is right at the intersection of direct clinical care, education, research, and administration. So I don't know of anybody else who's better qualified to tell us about the state of FQHCs. And I'm really looking forward to her talk because she's had a long history as a nurse and with her advanced degrees in really looking at health disparities through a systemic racist lens. Fred Wamboldt is now a professor emeritus from National Jewish Medical Center and the University of Colorado. And he has primarily focused his career on research with people with chronic medical illnesses, looking at both their mental health, but also how to improve their physical health. And for the second half of his career, really got into community research. So he's going to give us a different lens of how one might work with FQHCs. And I'm going to let them both take it away. I think it's going to be a very exciting meeting. Thank you.
So good evening, everyone. Thank you so much. My name is Roberta Waite, as mentioned. It's so wonderful to co-present with Dr. Wamboldt. We're really going to be focused on advancing health equity at FQHCs by working with community, patients, and healthcare providers. And as mentioned, I have the privilege of working in one of the FQHCs in Lower North Philadelphia. Really, I'm going to highlight some of the work that we do there, and I look forward to discussion as well. So just as a roadmap, what I plan on doing during my time is really talking about the model of care that we use at the FQHC where I am, which is the Stephen and Sandra Sheller 11th Street Family Health Services Center, and looking at some of the associated challenges, and then also discussing how we've moved towards creating a culture of racial justice and highlighting the benefits of partnering with community. That's a lot, but we're going to try and, work our way through there, but maybe some, like I say, more things can be discussed during the discussion. So I always think it's important to sort of unpack a little bit about the history, because while I am there currently as the executive director, I want to share with you a little bit about how the health center really got started. And it's been in existence since 1996. And Dr. Patty Garrity, who's at the top picture, she is the founder of partnership with community in the 11th Street corridor, which is the immediate area around the health center in 1996. And quite often in discussing and having discussions with Patty, she came down from the South to Drexel University, and they know they wanted to create something within this space. And she was well aware that within that area, we are fully inundated with a lot of higher education institutions, and many community members really are tired of being surveyed, questioned, really information being taken from the community members, but them not benefiting at all. So she was quite aware of that. So it took some time to cultivate and develop a trusting relationship, which took place over a number of years. And then really looking at what were the community defined needs, not those community defined needs that you can look up within the state and the city health department, but what were those things that community members wanted? And those are the things that were initially addressed at that time. And just to give you an example, several of those things were community members wanted to learn how to do CPR because ambulances were not always fast to respond. So public health nurses set up at the housing developments and taught individuals the whole complex how to do CPR, supporting community with food, because halfway through the month, oftentimes families ran out of food. And so partnerships were developed with food banks. And there were numerous other things. And after that time of being there, and communities seeing that she was serious in staying there, they started to develop a relationship and really identifying, okay, what does community really want within this space? So they did a future search, which involved community organizations, some political representatives. And from that, the community identified they wanted a health center, but not just a health center where they would go when they were sick, but a health center where they could go to be well. So it would involve a lot of different services that I'm going to talk a little about later, but more than just clinical services, but services that could also focus on health promotion and wellness. And really, it did focus on a lot of historically excluded populations because these were and underinsured community members who would be highly utilizing the services within the building. So after community and the partnership developed, they did an assessment. So they were fine with doing an assessment then because it was identified a health center was wanted to be secured. And so on the first grant from HRSA, they did get it. And with that funding, they also had to look at the long term because with that funding, you had to make a 25-year commitment. And so that's at that time where additional technical assistance was received through HRSA, and we linked with an FQHC because that would help with sustainability with the federal reimbursement for services. And so we linked with Family Practice and Counseling Network. And the bottom picture here is of Donna Teresi, and she is the founder of FPCN. So we are the only FQHC that's run in partnership between a university, because a university cannot be an FQHC, and another organization. FPCN, or Family Practice and Counseling Network, they have a couple other sites that are run independently, so they're not running in collaboration with other organizations. So it's a unique situation, but that's sort of the background I think is really important to share as well. So this is sort of a visual here. I'm more of a visual person. So you have a university, you have FPCN, and the arm of that, or the parent organization of that, is RHD, which is Resources for Human Development. And this sort of shows you the intricate complexity of running the health center, but also when you're wanting to have a large impact and you have mutual goals, these are the type of partnerships that need to be created. So how did I come to work at the FQHC? So while I was part of Drexel University and starting off as a brand new faculty member in 2003, I knew nothing about the FQHC. But during my time, and I started a postdoc, my research area was really focused on African-American women and depression. And so it was within the health center and within the community that I did conduct my two studies. And from that, during that time, you report back out to community as well as to the staff members at the FQHC what the results were. That's just a structure that's built in. And the director, Dr. Garrity, really wanted me to stay on and do more. And because a key piece that really was revealed from the qualitative research that I did was a lot of undiagnosed and untreated trauma that the women shared at that time. And so with that and moving forward, I did become the research scientist there, replicated the ACEs study, and that moved us into a whole genre of trauma-informed care, which I'll talk a little bit about later. During that time, they developed an assistant dean role for me there, so I took on additional responsibilities. So part of my role was faculty member and then assistant dean. And then over 3 years ago, I did take on as the executive director and associate dean. But my work there really has been embedding and development of understanding trauma, its impact, its link with racism, and also developing more of, I guess, heightening racial literacy, awareness, and understanding of how racism intersects with health as well. and promoting anti-racist practices, which I'll unpack a little bit more as we progress and move forward. So racism is a huge component of what impacts health, and it's very clear within the community. I would say we know that nationwide, but specifically we care for a lot of historically excluded populations that it impacts at an even greater amplified level. So we know, at least in discussion, it was a newer term to me, but racism is a socially transmitted disease. And it's something that's really important that needs to be understood, discussed. We need to have more conversation, become much more literate and comfortable with having conversations about it if we're actually going to do anything to dismantle or address it. It's taught, passed down, but the impacts on children and families and communities are significant, particularly when we look at it from a health perspective. And this is across the lifespan. So as I identified, right now I'm the executive director there. The FQHC, just to give you a little bit more information, is a level 3 patient-centered medical home. So we care for individuals across the lifespan from the age of 3 days old all the way up to death. We provide integrated services with significant clinical services as well as health promotion services. And as I mentioned earlier, it's not even just about providing the services, but it's about how you do what you do. And so because of our increased work around trauma-informed care, we really took on and decided to move forward with the sanctuary model. And we really stuck with this model because it takes an organizational stand. So it's not just looking at the provider and the patient, but it's looking at that as well as colleague to colleague, the environment, the community, policies. It takes a look at the entire organization. And then we also applied anti-racist practices. A big piece of what was revealed from that sanctuary model, because you get everyone involved, it's not just administratively driven, it's everyone from security, medical assistance, all the way up through administration. One of the big pieces that sanctuary does not explicitly address is racism. And because of the discussions and conversation as we were going through the modules and things that we needed to do in this process, a whole lot of things started to come up that we put in a parking lot. And I said, hey guys, if we want to be truly authentic, we got to deal with these parking lot issues. And those parking lot issues had a lot of themes. And at that time, I was there working as the research scientist, but it was really focused on issues around subjugation, racism, diversity, sexism. All the isms were in there. Power was a big piece in there as well. And so when going through that process, staff decided they wanted to do something and they didn't know what they wanted to do, but it was over a 9-month process of deciding, do we want a deeper focus on diversity, equity, inclusion? What is it we wanted to focus on? Do we want consultants to come in? And ultimately, staff decided they wanted to really do something of their own. And so we had partners from RHD, they had gone through training with Undoing Racism, and we started Undoing Racism groups. And so these groups have actually been taking place since around late 2014. So we've been having these discussions for over a period of time. And so the work that we're developing now from an anti-racist culture, it's been built up over a period of time. And that's needed with culture change. So to highlight more specifically from the community, things they identified they wanted, we provide primary care services, behavioral health, oral health. Again, it's across the lifespan. Within primary care, there are a lot of integrated services from nutrition. We have partnerships with medical legal partnerships. So anybody who needs assistance with anything except for criminal, those things are covered. We also bring services over from the university. So partnering with the law school for advanced directives and living wills. We have integrated behavioral health consultants that work with children and families, even preconception all the way up to age 17. And then we have another behavioral health consultant that works with adults. We have a psychiatric nurse practitioner. And then we have medical providers that come in, like podiatry, cardiology, and so forth, once a month. Our podiatrist is there once a week. Our cardiologist comes in once a month. And behavioral health, we have a very broad span of behavioral health with traditional talk therapy led by licensed clinical social workers, licensed professional counselors, psychologists, and we also have creative arts therapists, which is really important, particularly when you're working with a lot of trauma. So art therapy, music therapy, dance movement therapy is integrated in there as well. Oral health, we have dentists, dental hygienists, AFTAs, again, our primary care and actual oral health, those are our largest departments. We have about 6,000 patients that we care for, and we have about 27,000 visits annually that come in. As I mentioned, we also have health promotion, so mind-body services, a fitness center, Reiki, yoga, Tai Chi. So we have a number of different wellness services as well as education. Some of our education services has transitioned with COVID. We've had much more, and we're hoping to be able to bring many more back in person. So our cooking groups have ceased since COVID, but we did have a lot of cooking groups, diabetes education groups, and so forth. So this is just a glimpse. And we, we also pull over services from the university. So we offer physical therapy twice a week. And these are services that all of our health promotion services are free. So anyone within the community can utilize those services. You don't have to be a patient receiving primary care, behavioral health, or oral health care. And we also have a 340B pharmacy that is on site as well. So it's great to have a pharmacist as part of the team as well. The individuals who have difficulty getting in, we have a van driver. We have a van that can go pick up patients if they cannot get services via our social worker through any other mechanisms through their insurance. So this is just a high level overview of some of the services that we provide at the health center. Again, I'm visual. I just wanted to share a little bit more. So as you can see, these are, again, the fitness center that we have, our art therapy, dance movement therapy, yoga room. These are just some spaces, and Maleki is our fitness coordinator. I failed to mention that while our building was built in 2002, we started in 1996. The building from the funds for HRSA were built in 2002. In 2015, we did go through an expansion because we had grown significantly. So this part here that you're seeing now is part of the expansion that we have. We do a lot within the community, also with students from the university. While we do, which I think is a wonderful experience for our students because they learn from community members. So they have their expertise, the community has theirs, and it's a great experience for both. So students come from many different majors over to the health center, both as interns, as co-ops, because at Drexel, we have a co-op program, and many different sort of majors. As you can see here at the bottom, because as I mentioned in reference to COVID, we were one of the first within the city of Philadelphia to actually have walk-in and drive-up free COVID testing for community. So not just for our patients clinically, but anyone within the Philadelphia area. Initially, when COVID hit, there were many big centers, but they were out of the way. And so there was a disparity right there because if you couldn't drive or didn't have a vehicle, you couldn't get tested. So we had both drive up and walk up for COVID testing. And then we also provided the vaccines as well. And we provide all of them, the Pfizer, Moderna, as well as the J&J. So when you're looking at challenges with the health center, I would probably say it touches all of these areas. Again, I'm a big believer in culture. Again, culture is huge because I think strategy will eat culture any day of the week. So you really have to take the time to develop that culture and develop people as well, making sure you have clear not only what you're doing mission-wise, but why you're doing it. But it impacts environment, technology, policies, again, people, leadership, as well as the organization as a whole, but people are the key driver. So I always say, you know, developing individuals, and when there's openings, for individuals to come in, that's a prime opportunity. Because as far as I'm concerned, you don't want to hire for what is, you want to hire for where you want to go. And so being used to change and being comfortable with change is a big component. And I see, you know, particularly in the work that we're doing, because again, we have deepened our work and committed to working with community. And really it is a big challenge because many staff members have been quite uncomfortable with a lot of the work that we're doing, but we're committed to moving forward with our learning in reference to promoting health equity, because you can't even talk about health equity if you're not going to talk about racial injustice or social justice as well. And so we see it as a feat. You know, there are different sort of levels that you get to, but it's for the long run. But I think the most important component also is, as you're learning, there have to be some outcomes from that as well. So it's not just to say we're going to continue just to learn and not have some expectations at different points along the journey. So there have to be outcomes that are associated with the work that we're doing. So for me, I think one of the biggest things is, you know, when are we ever going to get to a point of where we have to stop having learning about anti-racism in so many different ways where it's not a choice. I think it's great when you have leadership that's on board that continues it, but if it's not part of the leadership, you know, sometimes it can be optional at different places. And to me, that's a problem because it really has created and probably is one of the root causes of so many of the inequities that we have right now, not even just in health, but in health is a major driver. So when it can stop being a choice of learning about it and actually acting on it and creating interventions and assessing and evaluating them, that's a big feat. And that's something that I want us all to be working towards. So when I think about the providers and the practitioners, I also think about, you know, people must understand, you know, why we have these inequities. I think there's a lot of power in understanding why. It forces us all to really dig deep and think about the origins of health inequities and why they have been sustained over centuries. And these have to be very explicit and intentional conversations that take place, not even just with colleagues, but even with students, because otherwise many people will think things are the way they are because it's just happenstance. And we have gotten exactly how our country and our policies and our structures have been designed to give us. So it's not happenstance at all. So these conversations do need to be widespread in our country among persons seeking to promote health. They may not be easy conversations, but I always say, let's get comfortable with discomfort, because if we're not in that space, then you're really conforming, used to doing what you want to do in a place of complacency. So organizational staff must define the why patterns of inequities exist, not what's driving them, but why. This will drive decisions towards addressing the problem. So really having staff in all roles and all spaces really think and reflect on that is really huge, and even talk about what they think it is. I wanted to share this quote because to me, this really is the pinnacle of all of this. James Baldwin is one of my favorite. So I'm gonna just read this. History, as nearly no one seems to know, is not merely something to be read, and it does not refer merely or even principally to the past. On the contrary, the great force of history comes from the fact that we carry it within us, are unconsciously controlled by it in many ways, and history is literally present in all that we do. It could scarcely be otherwise, since it is to history that we owe our frames of reference, our identities, and our aspirations. So I think that understanding history, no matter what you're taking up, is key. And that's why I also wanted to share just briefly the history of how the health center started. So when we think about health, I'm going to take it back because through history, even before there was a USA, again, particularly, and I'm giving an example for African Americans, chattel slavery was huge because there are many other groups as well who've had have been significantly impacted. But chattel slavery has been a core component that has was fueled by racism, continuously is. And I think these three areas, the social determinants of health, the political or the structural really determinants of health, and the implicit bias, microaggressions, and prejudices all fuel health inequities that create the disparities that we see presently. This is a different diagram that I often use, particularly when I'm working with nurses. Really, you know, oftentimes there's discussions on race, and race is not the problem. Is how race is conceptualized socially, and oftentimes it's racism. It is racism, not oftentimes. It is racism that fuels and produces health disparities. And these are the mechanisms how, and this is how it plays out here. So this just provides another visual. And for a last visual, particularly as you're looking at the pathways and how it happens, particularly when you're thinking about racism historically from settler colonialism and racist ideology, and how that really fueled a lot of ideas, stereotypes, beliefs, et cetera, and ways of thinking. And now that impacts health and racial inequities in health as well is really important. So these are the things that of what makes people sick, and how health disparities are driven by social and economic inequities in many of these different ways, from economy, where we live, education, food, community, healthcare. And when we look at these, a lot of this we would identify as social determinants. So we see healthcare is a very small piece, maybe 15 and max 20% of what impacts health. So most of what impacts health is outside of particularly acute care, bricks and mortar, but it's where people, you know, live, work, and play, and those are all guided, I would probably say, by many policies that are in effect. And when we work with healthcare providers, when they interact, you know, with patients, it's important to look at some of these specific conceptual areas that are contributors to racial disparities in healthcare, you know, with oppression, and really actually, I would say, understanding what these terms mean between, you know, with oppression and stereotype and discrimination and prejudice. And with healthcare providers, and I'm going to speak specifically to nurses, but I think for many healthcare providers, you know, it's challenging for them to think about that because, you know, many of them get into the profession because they want to do good. They want to help others. And that's admirable. But wanting to help others, but also continuing to conduct yourself in the ways that we often do, you can be complicit with, and we have been complicit with upholding and perpetuating the structures that promote health inequities and disparities that we see. So really unpacking that and having these deeper discussions and understanding, you know, before you're a nurse, before you're a social worker, psychologist, physician, or anything else, you're a human being, you're a person. And then that drives a lot of what you do, regardless of your degrees that you have. This is a framework I also like to use, seeing, understanding, connecting, and acting, and looking at seeing the different paths from stereotype to oppression, understanding, connecting with policy, and then acting. Because while right now I think a lot of people have been in this space of doing a lot of reading, which is really needed, because again, oftentimes it's not taught in school. Intentionally, it's not taught in school. And that's why we have so much of the strife that we have right now for it to be taught in school. We have significant resistance. So we do have to learn about what it is, but understanding and connecting to how it links with oppression, to the policies, and then actually acting to create change. So it's not just enough to know, we must understand and act as well. So these are just some of the exemplars, not everything, but some of the exemplars I would say that we practice at the Health Center related to health equity. As I mentioned, we have our monthly Undoing Racism groups, which have been very powerful over time. They've changed significantly, but they've had a great impact on many things that we do, including policies and hiring and who's involved and the different rubrics that we have. Because what I can tell you, when I first started there was no process for hiring. It was much more of who the executive director wanted to bring in there. And so you did see most of the leadership, they were all white. And you had most of your medical assistants or patient service representatives were racial, I would say Black and brown population. We have integrated our anti-racism education into our sanctuary trauma-informed training. So as I said, we see these as one because racism is trauma. So while we continue with our trauma-informed training, we have updated it to integrate our anti-racism work. We also 2 years ago started racial affinity groups. So we have a white affinity group and a BIPOC affinity group. And so what we've done is have alternated it with our Undoing Racism group. So we have one each month, and these are staff-led. So it's not somebody coming in, but staff are learning. It's great for the learning component, but also getting to know the facilitator who's working with you. Because one of the big things that we have as a guideline is we have individuals from different races who co-facilitate these groups. And there are people in a myriad of different roles who can do it and who have been doing it. We also in the past 2 years developed an anti-racism advisory committee. And this committee consists of both community members as well as staff members. So that's really new. And that's been a really great experience, very educational, insightful. And that's in addition to our community advisory committee that we have. We recently started to have coaching for reflective supervision from an anti-racism lens. About 4 years ago, we started reflective supervision. That's something common that happens in behavioral health, but I really think it's important for everyone in every role in dental and primary care. And it was very new for them because they didn't have reflective supervision. But over the past year and a half, we did get training and education on utilizing that using an anti-racist lens. So that also has been helpful because now everyone is expected to obtain or receive reflective supervision. And then also how we've started to normalize over the past 2 years is there is something on our meetings. So we have various meetings, but there is something specific on our agenda that focuses on anti-racism or racial justice. As it relates to health, learning, in some way, shape, or form, it is on our agenda intentionally, just like our regular sanctuary check-ins. So embedding and integrating it is important. Just to show a little bit, so how is racism a trauma? In these pamphlets here or these boards here, this was developed by our anti-racism advisory council with community members and staff. And so these are poster boards in addition to our sanctuary poster boards and others that are within the health center that everyone can see. You can see here on the right, sort of our fundamental guiding principles for sanctuary, our 7 commitments that we use. So, those things are there as well. And we have others that are around as well, because visually it's really important to see these things. So therefore staff or visitors for anyone who comes in. So they are scattered throughout the building, not just for staff members sort of behind locked doors. Just to highlight really quickly, I wanted to unpack a little bit about some of the social influencers, because while I showed a model of our clinical services, I think it's also important, at least for me, I wanted to see how are we impacted from a social standpoint, because I don't expect for us to do everything, but really to see how we do support from the social standpoint, and that is from our social justice and working with our affinity groups, our psychoeducational groups. That's something else that we do. We have a staff and a community member who leads psychoeducational groups on different things around trauma and racism as well. We have food justice. We provide farms and family food boxes And we have other resources that support community with food, as well as some of our other wellness and community health services. So this we're sort of building out just to see what we provide ourselves, but it also helps to inform us where we can cultivate and develop more cross-sector partnerships with other organizations to fill in some of the gaps. These are some of our partnerships that we have right now. Again, I look for partnerships with many different, from churches to schools, religious community organizations, and other types of organizations as well. And so this is just a sample of when you're working in community. It's really important to work with other agencies as well. And just sort of to close up, sort of to achieve health equity, these are some of the things that I think is important to keep in mind. To create or enhance, again, I think we try and do as much as we can, but we can do so much more through partnerships. I think that is key. Focusing on social and I think also in structural determinants, trying to build capacity, looking at how we're going to move towards change. And again, it's not just about knowing and understanding, but it's also about action and assessing and evaluating the outcomes from that action. Because things may not work out well the first time, and I'm a great believer in let's try it, let's fail, and let's just fail fast if we do, and let's modify and move forward. And so I think that's really important to evaluate and try different modes of things, and working with community as well, because community's voice drives a lot in the work that we do. And these are just some of my references that I used. And that's it for me. I want to thank everyone for your precious time and listening to some of the words that I wanted to share about our model of care. And I look forward to the questions after Dr. Wamboldt presents.
While I'm getting my slides set up, I really want to thank Dr. Roberta Waite for such a wonderful presentation. She really goes through why I have been attracted to working in the family qualified health centers that I've been able to, or excuse me, federally qualified health centers I've been able to work in. And we should have a screen up, I hope. And it's really because people who work in these clinics are at the forefront of fighting for health equity in the face of systemic racism. So you heard why I think these are really terrific places and why we're lucky to have people like Dr. Roberta working within them. So that being said, I've never been employed by a FQHC, although I've done a lot of collaborative projects with them over the years. And so I'm going to talk about a recent one, the Campaña Bienestar, or the Wellbeing Campaign, as a way of showing how people from outside a FQHC can still partner with them and provide useful services. So, but before I do that, a brief story of how I got to work with them in the first place. So after finishing my psychiatry resident, I had the privilege of spending 4 years working with Dr. David Reese, Peter Steinglass, and many other talented people at the George Washington University Center for Family Research, where I learned how to conduct state-of-the-art family research, and equally important, I learned how to get funded to do so. In 1989, I moved to National Jewish Health in Denver, a national referral center for chronic respiratory disease, and I was asked to start a research program in patients with asthma, which early on I did with my wife, Marianne Wamboldt, and Dr. Tom Russler, who's a current Family Process Institute board member. And we quickly found that many children and adults who were admitted to National Jewish showed very poor adherence with their asthma treatment. And this was very surprising to us because the vast majority of our patients came from out of state, and even the in-state ones, most of them were out of network. So to come there, patients had to get their insurance's approval to pay National Jewish, but rates of non-adherence were very high. So we got intrigued by this, and that's where we started our work. However, after a bit of doing this work, I had my cast moment, named after Isabel Wilkerson's book, tremendous book, about how systemic racism remains embedded in America because we have a caste system where whites are on top and other people are down lower. And it came when I presented findings from NIH-funded research into the determinants of children's behavior to an audience in Australia. So I'm going to tell you briefly about the samples we had. We had children hospitalized at National Jewish for intractable asthma. We had children who were participating at National Jewish in the National Heart, Lung, Blood Institute's Child Asthma Management Study. And we had two groups matched from the community to the camp sample, kids with asthma attending Denver Public Schools and kids with asthma insured by Kaiser Permanente, Colorado. And all showed the same primary determinant of asthma. And we were puzzling about what the mechanism of this might be, because in NIH research, you're supposed to find what's the mechanism behind an illness and then devise an intervention that's going to treat that problem. And we were working mightily on this, but till the person in Australia gave me the answer of what it was about. So here's one slide just showing that what we found is that child race explained the highest percentage of the variants. It was whites did better with their adherence than all else. So I don't want to talk about that because we were totally off with what we were thinking. So this very nice gentleman said, Dr. Wamboldt, you Americans seem to like to sort people in racial boxes. But from what I see, nothing good ever comes from your doing this. Here in Australia, we classify people as Australian born, not Australian born, meaning new immigrants, because they need extra getting settled into our country. And our Aboriginal people, because we have seriously mistreated them over many years, and we need to set that wrong right. And this, his words right there hit me like a bolt of lightning, because I very quickly realized that these differences weren't family-based effects. These were effects due to systemic racism, because we still in America don't treat our new immigrants very well, quite shabbily indeed, and our African-American people, we continue to treat poorly, despite the fact that rich white people brought them over to this country as the part of chattel slavery. So it also suggested to me that the people from Australia are doing a heck of a lot better than we are on this front. But nonetheless, I haven't moved there yet. But this got me thinking about my research. And here's a photo of a button I wore through much of the 60s and 70s, because I was pretty committed to follow Eldridge Cleaver and want to be part of the solution, not part of the problem. But to be part of the solution, what I hit upon was starting to get retrained into more community-based participatory and action research. So just like I had great teachers at GWU and DC, here's my teachers in community-based participatory action research. These are the community advisors for 2040 Partners in Health. Community-based organization founded in Denver in 2006 as the Stapleton Airport was being decommissioned and as Denver International Airport was coming online. And their mission was to work with the neighborhoods surrounding the old airport with the health inequities and health traumas that come from living next to an airport. They were terrific. I got involved with them because the people from the Department of Family Medicine at Colorado did a baseline survey of health disparities in their neighborhoods and found they had high rates of uncontrolled asthma. And surprisingly, Latina and African-American teenage girls were adopting smoking, which typically wasn't happening in anybody but white teenagers. And they seem to be doing it for the same reason white teenagers smoke, which is to manage their weight. So because of this, they invited me to work as a physician who had some experience with these problems and help them figure out what to do. But I think along the way, they taught me more than I taught them. And I'm going to share two things that I really learned from them. The first is that when you work with people who live in the community, they really know how to message and intervene with the people of the community. So as we're discussing teenage smoking, one of the women in the groups said, "Hey, Dr. Fred, I know what we can do to help our girls with smoking. And I said, boy, I can't wait to hear what you have to say. And I'm sure we all want to hear what you say. She got a big smile on her face. And she said, we're going to print up t-shirts for our girls. And I said, and what are you going to say on those t-shirts? And she got an even bigger smile. And she said, they're going to say, my bod smoking without smoking. So we printed up those t-shirts. They knew who to give them to get them out to the girls in the community. The girls wore them. The community started talking about, do we really want to have our girls think that they have to be skinny like white girls to be a success in our community? And they thought about the businesses in the community they had to talk with about selling cigarettes to their girls. And when we resurveyed, it went down. Now, what do you think the chance is that this guy here would have thought about printing up t-shirts with my bods smoking without smoking? Yeah, the probability is below zero, my friends. But lesson learned of why you need to work with the people in your community and learn from them. Second thing that I learned from them is that they called themselves 2040 Partners for Health for a reason, even though they were founded in 2006. And the reason is they realized that some of the health disparities and health inequities that they wanted to solve were going to take a long time to work on. And one of them was the fact that when Stapleton Airport was closed, the land was redeveloped as a community primarily for upper middle class whites. And that was bad. But what was really bad about it is when the name Stapleton could have been changed, it wasn't. That new neighborhood was called the Stapleton neighborhood. And the reason that made them literally sick is that Benjamin Stapleton was the mayor of Denver through much of the 20s and 40s, and he was KKK through and through. And in fact, through much of the 20s and 40s, the KKK ran the city of Denver and the state of Colorado. So why wouldn't this name be changed? And they made a commitment that they would work with other organizations in town to get that changed. Now, it didn't happen right away, but I'm very pleased to say that about a year ago, the name was changed and we got a KKK racist name out of our town. And, 15 years of working on it, not a bad thing when you can do that. Now, I told you my words on this, but there's a man much smarter and much more principled than I've ever been who says it more eloquently, that change is going to come, but it's going to take time and justice will arrive. All right, that said of how I got here, I'm going to switch to talking about a project that I did, one of the last projects I did, and before retiring in FQHCs, the well-being campaign, or La Campagne Bienestar, since we treated a lot of Latinx populations. It was a 4-year project, and our goal was to sustainably improve the clinical weight management practices in 2 large Colorado FQHCs, the Salud Family Health Centers and the Metro Community Provider Network. We're funded by the Colorado Health Foundation. I'm going to tell you just a bit about the Colorado Health Foundation because they have an interesting history. As for-profit hospital businesses started moving into Colorado, they, of course, bought up community hospitals. And the problem with that is when a community hospital made profit, they shoveled most of the profits into improving the health of their community. When a for-profit hospital came into town, they gave as much as they could to their shareholders and to improving their business. So Colorado said, no, you can't do this. You still got to keep giving some money for community health. So they did that for a number of years. Some people think it was really short. Some people think it was a good deal. But nonetheless, after what I think was a short period of time, they came back to the state and said, we really aren't sure we want to pay you money every year. How about if we just give you a nice lump sum? And then we can keep all the profits we make in your state. And whether that was a good idea or bad idea, I won't share my opinion on that one, but you probably can guess. They accepted the deal, and that led to the foundation of the Colorado Health Foundation, which really has proven good for our state. They are the largest non-governmental funder of health promotion and community health activities in Colorado, and they have a commitment to improving the weight of the state of Colorado. And I'll tell you a little bit more about them in a bit. But first, let me say a little bit about the clinic. So Salud Family Health Center serves 9 clinics in northeastern Colorado. They've always had a focus on migrant and seasonal farm workers because the doc who set them up worked for quite a long time with Cesar Chavez in California. And that remains an important legacy of their institution, although now they are the major primary care providers for the entire northeast corner of Colorado. MCPN is 23 clinics in Metro Denver. They focus on under and uninsured populations and serve a lot of poor people, African Americans and Hispanics, and homeless people. And so the population served and the services that both clinics offer are quite like what Dr. Roberta talked about her clinics providing. The Colorado Health Foundation wanted this to be a community participatory action research project. So we had people from the government, we had people from the local communities, we had people from the clinics, so on all levels, management, patients, providers, staff, with input. And one consistent thing that we had heard from them is when you show us imaging of people who are losing weight, please don't show us skinny white women in yoga pants. Now, my wife's a yoga teacher, and she occasionally wears yoga pants, so I'm kind of used to it. But I got their purpose, and I especially got it once we started looking for images and health promotion materials related to weight management. You're surprised about how that market is dominated by skinny white women in yoga pants. So you'll see with their input, we designed things to show people who look like they're people from the community. So this lady here is standing in front of the high plains of Colorado prairie grasslands. And we did this with urban environments as well. And I think it was an important step of listening of how things should look, which Dr. Roberta also talked about in her clinic. Now, our goals were to change the culture on the provider staff level and patient family level in terms of attitudes and behavior, that you can lose weight. It's going to require you to do some lifestyle change. And there's not just one way to do it. And then identify and reduce barriers from patients, families, provider staff, and systems to do this. So we took a lot of approaches here, and I'll let you read through them. But the most important I want to tell you about is that what the National Jewish Fit Logics program was. So, but 10 years after coming to National Jewish, since I had experience in respiratory disorders and also in community work, they asked me to serve on a group that was going to try to set up a telephonic and web-based smoking cessation program that we called Quit Logic. It's done well. We've now the largest provider, nonprofit provider to 22 states. We serve Canadian provinces. We serve a number of Native American First Nations communities who we have contracts with. So it's been a good success. During the Obama era, as the Affordable Care Act was coming online, one of the unfunded mandates to this date was to pay for treatment for obesity or overweight status. Currently, in medical settings, and I think this is still true, even though I've retired a couple of years ago, so you might want to check with your providers about this, but you can only get paid for counseling somebody about obesity and weight problems if they have a weight-related disorder like diabetes, and then it gets paid for. Well, the Colorado Health Foundation thought, boy, if an intervention like this could work in these clinics, wouldn't that be great? And wouldn't it be good to have data that tries to get weight itself be a condition that insurers would pay for? So they allowed us to run 20,000 providers, staff, and patients through our program. And we had the funds to do that. And it worked. That's a different talk, but it performed quite well. So our timeline, we had 4 years. The first year was to really get information through a variety of means from what the community wanted us to do with this project. We had a few ideas, but we wanted them to tell us what was the right thing to do. And we did a FitLogix demonstration with providers, staff, because we wanted to get some people who went through that program, lost weights, and would be champions within the community. Because in these communities, most of the providers and staff live there. Their patients saw them in grocery stores and churches, on ball fields, and we wanted to have some people who had lost weights, who might be champions, or who somebody could walk up to and say, hey, you lost some weight. Do you think I could lose weight in your clinics? The other thing we did is we ran through patients from a couple clinics so that our counselors got experience dealing with the people from these clinic populations. Years 2 and 3, we worked with providers and staff of what was it going to take to change your practice pathway, to redesign it so you could better do guidelines-based weight management. Years 3 and 4, evaluate results, and most importantly, make sure that what we were doing was going to be sustainable. Because the worst crime you can commit when you come from the outside and work in a clinic on a grant is have your entire program crumble the minute funding's over. So sustainability, we were working on from day one. So all of the evaluation was done by a group that Colorado Health Foundation always. This tells you who they got in touch with and ways they got on the data. But it was their data that we used to work with people to decide what we're going to do. So the major thing that we found out, and the thing that everybody thought we needed to work on, is virtually all patients have their weight documented as they enter the clinic as a vital sign, usually by the medical assistants. And in these clinics, as you'll see here, about 70% are overweight or obese. But when you walk over to the problem list, only 19% had their overweight or obese status listed on the EHR, on the electronic health record. Now, for those of you who don't know what the problem list, in the old days when we had paper charts, the very first page had the problem list on it. When you talk to somebody about a problem or identified it, wrote it on the problem list. Now you enter it into the problem list on the computer. But this really is what you own up with the patients to be what you're working on. And if less than 20% of patients were having this move to the problem list, everybody agreed this was a problem we had to solve. So what we learned about why this was happening is patients felt much more comfortable about talking with their weight to the providers than the providers believed. We originally thought providers just thought they didn't have time to deal with this, but they actually didn't. This was during the Affordable Care Act, and people came in who had had insurance for the first time with all kinds of long deferred medical problems. So providers had 15 minutes per patient, whether a new patient or a follow-up. They were working through their lunch hours. They were staying after the clinics closed to try to get their orders sent off and to write their notes. And they really didn't have time. Providers also felt they didn't have the support or tools. And they raised the issue that nobody ever comes in to see me who says, Doc, will you help me work on my weight? And they ask, do you think you might be able to change that? And finally, we're all not calibrated to see weight problems anymore. And that was true of me. When I found that I was going to do this grant, I stepped on the scale for the first time in a long time, and I was 5 pounds into being overweight. So if I was going to talk the talk, this doctor was going to walk the walk. And, I did what I needed to, and I had my own experience to learn how you do this and how you can succeed with this. Now, this just shows how the providers responded to it. There was one thing I think the providers didn't have right, and we actually addressed this with them, and we jointly sought out data to show this wasn't true. And this is this one right here, that the patients might not have the money they needed to eat more healthy and to move more. And I think that it might be true that they couldn't buy their food from whole paycheck, and they might not be able to get a gym membership. But there were other ways that they could do this. And so we really worked with everybody to figure out how could we learn about that, and how could we see if that's right, which we found it was, and how could then we move forward with it. Now, on the patient side, you'll see that about 2/3 of patients know that weight is related to diabetes, heart disease, high blood pressure. All these other weight management problems, almost nobody knew about. So this was identified as probably being a problem due to the fact that providers weren't discussing weight. So the clinics owned up to this and said, we need to learn how to do this. Now, the problem was working 15 minutes per patients. The leaders one day came to me, both clinics in separate days. They came to me and said, okay, Fred, you can do this, but you got to help our providers be able to talk about weight and get it on the problem list in 30 to 90 seconds. So we accepted the challenge, and hold on to your hats, fasten your seatbelts, because we're going to show you how we had a very brief discussion about weight and then recorded it on the problem list. So tell your patient their weight's the problem, if possible, related to the reason they came to see you today, offer them resources and tools to use if the patient wants to, and then use exit strategy if the patient isn't letting you finish the talk early on that day. So BMI over 25, you say, Mr. Salazar, your weight's been in a range that's a problem for your health. Some clinics came up with this really great idea. Since the MAs were recording it, have the MA on a little card, write your weight, your BMI, and circle where you were, and then say, your provider would like you to hand this to them when you get into their exam room. Most of the time, people would do that. It queued the provider right up that they could have a talk with them. Every once in a while, somebody would get in the room, not give the provider a card. The provider would say, didn't my MA give you a piece of paper to give me? And you'd get an answer back, something like, nobody ever gave me anything. And the provider knew that this was a patient you had to have that brief talk with in a very different way, and we'll show you recommendations for that in a bit. You advise them about the risks. Since you have no weight-related problems now, this would be a great time for you to lose some weight. Losing weight is one of the best things you could do for X, Y, or Z. What's your weight management issue? You could do it. Working on a healthy lifestyle would be great medicine for you and your kids and family. We found a wonderful book published by the American College of Physicians, which was our next step. And as you see, these are not skinny white women yoga pants. These look like the people who lived in these communities. And so we were able to negotiate a great price for these, as well as get the PDF and permission to use the PDF within the clinics. And so the doctor would next say, look, here's a terrific book that offers suggestion how to manage your weight. Take it home, look it over, and then make an appointment to come back and see. And here each clinic had to answer what that C was going to be. See me, see my medical assistant, see our professional health educator, see a nurse practitioner, see somebody in our obesity management or weight management clinic. They all had to decide, but they needed to have somebody or some group of people who were going to take this on. And that either got it into the doc's hands and they knew they had it, or it got into somebody else's hands. This was where they could also suggest you were welcome to join the FitLogix program as a patient, and then put obesity on. So again, those of you from healthcare environment, look at those disorders. Which one's not related to obesity, eh? So it makes it quick. Now, exit strategy. So what happens if the patient gets upset and said, doctor, are you calling me fat? It's your choice whether to work on this side, but I wouldn't be the doc if you deserved it. I didn't bring this back since I think losing weight is the single most important change you could make to improve your health. That's my statement. Other people came up with different ones, but each provider had to have what were they going to say that they thought would help the patient understand, move on, get to talking about the thing they needed to talk about that day. Oh, doc, I can't believe you brought this up. Can we spend an hour today? Because I've tried all these diets. I've tried everything. I really want to know what you think's best for me, and then I can do it. But I really need your advice today, doc. Look, you came in today because of your back pain. Let's take care of that and then get an appointment for you to come back and see whoever's the right person in several weeks so that this can get talked more through with you. Here's the people who didn't hand in their card from the MA. I have no interest in losing weight whatsoever, doctor. Well, it's your choice. Just know that if and when you ever want to do it, we'll help you here at MCPN. We'll help you here at Salute. So that's it. And we worked with people. They found they could do it. We did a lot of role play and they got good at it. It was kind of fun for them to see who could do it in 30 seconds, who could do it in 90 seconds. I mean, people got engaged with it and they got good and people didn't mind. It worked. So what do you do next? So here's what the American College of Physicians book would say. You eat the healthy plate. You divide your plate in half. Half is fruits and vegetables, half's protein, half is healthy carbs. And the portion of protein and carbs is the palm of your hand and the thickness of hand. So if you're going to eat a chicken fried steak about 12 inches in diameter, you better have a palm that would make LeBron James really, really jealous. Now, the trouble with this was many of the ethnic people would say, this isn't our food. This is gringo food. This isn't our food. So the second option, and since I like my ethnic food, what I did when I had to face this is I downsized from a dinner plate to a salad plate. As long as you keep it piled to the same height and the same proportions, you decrease your calories by a third. And that's enough to get you starting to lose weight. Drink smarter. One thing that came out right as we were starting this study were fairly clear studies that if you drink sugary drinks, creamy drinks, they give you calories, but they don't promote satiety. They don't turn off your appetite. So they just come in there and you're getting the calories, but you're not losing your hunger. So don't drink sweet beverages, don't drink creamy beverages, and move more. And the book has lots of nice ways other than being a gym of what gave great stories. Many of the Latinx population were Catholic. And so we had this one guy who really came out and made a nice video for us saying that he had usually knelt by the side of his bed when he said his rosary every night. And he decided, why not walk around the house? He'd get more steps in and God would still be hearing him. And you know, what a great idea. I mean, this is why people don't need gym memberships to lose weight more. And then finally, as I said earlier, on the great expressway of life, there's not just one exit that leads you to success. The goal for the providers, for all the staff, help your patient figure out what's the right exit, what's the road they should be going on to manage their weight. Now, last couple things. So one of the other things you'll remember is the docs asked us, well, nobody ever says, Doc, will you help me with my weight? So we wanted to fix this, and we took a trick that I learned in tobacco control, that when somebody's in a clinic, when somebody's in the hospital, so a lot of times they're just sitting around, they're not doing anything. And so what could we do to activate patients to be thinking that they could get their weight managed here? And we did something, like I said, I did before. We put up big screen TVs hooked up to a computer in pharmacies, waiting rooms, various spots, radiology. And we played success stories from the FitLogix program from providers and staff who did it. So here's one young man telling you his story of how he lost weight.
I got to a point in my life where I felt like I couldn't, this was my lot in life. I'd gotten to a point where I was a size 42, I had swelling in my ankles and my legs, and I'd kind of gotten used to the fact that that's kind of where I was going to be at in life. My daughter and I were playing in the park, and she told me, she looked at me and said, Daddy, you can't run. And at that moment, I realized, you know, I need to do something. If I want to be around for this kid's future and my future and just have a better life, I need to get going on life and get active. I was probably about 285 pounds. I reached a high of 285 pounds, a size 42 waist. And I'm down to just about a 34 now. And I'm about 195 pounds. So in about a year, I've lost that weight and I've been able to keep it off. She knows she can't get away from me now. So she's moving around. She's looking behind herself really quickly to see where I'm coming up fast. So the old man's picked up some speed. You know, she can't outrun me like she could before. So it feels good. I can go.
All right, that gave you a flavor of that. So we had all kinds of other programming, but one other I want to show you. are some marvelous health promotion videos we got out of Mexico. Mexico and much of Latin America has been waging war against the refresco industry, the soft drink industry, just like we did with the tobacco companies. And so they've made some really great videos that show why you don't want to drink soft drinks and why you want to really focus on water. But they do it with the adults acting badly and the kids knowing better, which has sparked some great conversations in the waiting room. So here you go with this video.
¿Sabías que en la mayoría de los refrescos de 600 mililitros hay 12 cucharadas de azúcar? El consumo de refresco aumenta tu riesgo de obesidad, diabetes y enfermedades cardiovasculares. Pero ellos jamás te lo dirían, porque en una de esas les comprarías menos. Para hidratarse, tu cuerpo solo necesita agua. Toma agua. Y visita www.actuaporlasalud.
All right, so you got an idea of that. I gotta skip. You don't want to start that again. Let's me go this way. And okay, so we made water bottles to give to everybody in the clinic and to patients as they came in, so they had an easier way to drink water. Lastly, we were asked to form a partnership early on by the Colorado Health Foundation with Hunger Free Colorado. Hunger Free Colorado is a community-based organization in the state of Colorado that gives out food stamps and helps coordinate needy people with food pantries. We started looking into those who enrolled in FitLogics and found that 57% screened positive for food insecurity and accepted referrals to Hunger Free Colorado. About 1,000 were patients, about 150 were staff, meaning that 63% of patients had food insecurity. So based on this high prevalence, both Salute and MCM are now screening all patients as a vital sign, and we help set up an electronic program for them so that with the patient's permission, they could send a direct referral to Hunger Free Colorado, who'd get in touch with the family and help them get food, which made everybody feel good. So that's the end of my talk. Here you see some other people who made professional videos, and again, we're happy, none are skinny white women in yoga pants, so success there. And Dr. Waite and I look forward to your questions coming up.
Hi, I want to thank both of you for a very stellar presentation, very informative, and also just wanted to comment, and Roberta, you can correct me if I'm wrong, but the artwork that you showed in one of the slides, if I remember correctly, it was done by the community, that members brought that artwork in. Is that correct? Am I remembering that correctly?
The artwork that was done on the walls, they're actually of community members, but there was one person who did it. It wasn't a community member though who drew it.
Okay.
There's some other artwork though that community did, but not the one that I showed.
Having them on the wall, I mean, I was always so impressed by that because it showed community members that they had ownership in that, you know, and in working with the staff at 11th Street. Again, stellar. Thank you both very much.
And you're being honored when your picture's up on the wall. I mean, you know, to have your picture up in your medical home, how great is that?
I think even the work, because again, the other posters that we developed, that was part of their work. That's on great. The wall. So absolutely.
Mm-hmm.
Can I just make a quick comment?
Sure.
I really enjoyed both of these presentations, both for their systems perspective but I think this is the first time we've really talked about food and housing. And it's one of many pieces of the system. And Fred, I really appreciate that you were doing the food security screening that really allows you to connect with food banks and the food system, and Roberta, with you having nutrition and food as one of your elements. I really think this is essential, and not only social determinants of health, but it's a part of the political structure of racism. And I don't think it's always recognized. And it's not the only thing, Roberta, as you eloquently put in your models, but I truly, truly appreciate it. It's just not always put into the discussion. So thank you very much.
For those of you who don't know, at least the food security questions we used were over the past 2 months. If there been a time where you didn't have enough food to put on your family's table, or over the past 2 months, were you worried that you might not have enough food for your table? And you know, when you're trying to work on weight and health, if people don't have enough food, this is a tragedy.
Right, and those two items have proven to be reliable and valid against the much longer food security USDA module. So pediatricians, family practice practitioners can use this in their screening. And it has led to not only federally qualified health centers, but a variety of different health centers to have fresh food and vegetable mobile markets in their parking lots and to distribute fresh food to their clients. And one of the things that Roberta pointed out in her presentation is transportation is a huge issue for low-income clients. And so just even though you can connect people to food banks, can they get there? And so the schedule of food banks doesn't always meet the needs and the opportunities of families to get there. And so Roberta's model clearly identified, we're going to line up transportation for you to come to her wonderful facility. And also what people don't understand is that their buses and taxis will limit the number of food bags that you can bring onto public transportation. So imagine if you're a single mother of 3 to 4 children, which is the highest risk group of food insecure families, and you're trying to get on a bus and they tell you you can only bring 2 grocery bags, or a taxi driver will say, I'm sorry, you can't bring more than 2 bags of food. So I think as Roberta and Fred were pointing out, it's a very complex system when we think about social determinants of health and the intersection with racism, because they're so intertwined. And we tend to think about, well, are you at risk for diabetes? Are you at risk for, are you obese? Do you have coronary heart disease? Well, what kind of food do you eat? And how many people are living in your home that is probably filled with environmental toxins, which we don't talk about very much. But I truly appreciate this presentation on the backs of the other wonderful presentations that we've had. So thank you.
Barbara, as you were talking, I found myself thinking about having worked for Senator Rockefeller and the state of West Virginia, which was very obese and very poor. And it was your statement about the politics of food that I thought about, and how the state of West Virginia, at least the Senator Manchin, and goes against some of the policies that really would benefit greatly that state. So I'm just curious about, how do you talk to white people who are impacted and who don't seem to understand the politics of some of this, and don't think about the politics when they're voting and what it means for them?
I think of two things right now in this moment. I think of my good friend in Champaign, Illinois, who was the director of the Eastern Illinois Food Bank. He said, if you've seen one food bank, you've seen one food bank. So the politics of food is always local. So that you really, I've traveled all around the country visiting food banks and food programs for kids. And it's so true that the understanding of food and people's relationships to food and the delivery of food in federal programs is so determined by the local preferences for food and the local understanding of what food programs mean.
Marlene, one other thing I just wanted to share, it's quite interesting, is over the past 5 years, but really significantly over the past 2 to 3 years, around the health center, there's been significant gentrification. With the changing in the population, guess what? Now we're starting to get grocery stores.
Yeah.
We have an Aldi's, there were one grocery store that was really close by, but now because of changing in the population, there are actually 2 grocery stores, one Aldi's, which is a reasonable store, but it's unbelievable. Where none were there in the area before.
Yeah.
I just want to say one positive thing that has happened with COVID, if there can be a positive thing, is that the USDA has provided waivers on the National School Lunch Program so that schools do not have to fill out the major bureaucracy of allowing, so everybody can get free and reduced lunch. You don't have to document the poverty level. You don't have to figure out how many kids in that neighborhood are at the poverty level. Everybody, every kid at every school in the United States can get a free lunch. And so I am hopeful that this will become policy. The other thing is that SNAP benefits have actually increased to the level where they should be. So we have the opportunity to actually reduce childhood poverty by over 20%. I mean, that would be remarkable with this administration. So, as much as